Welcome and thanks for joining us on the Flourishing Life podcast, where we will be discussing what we see on the daily. We're Jackie and Tad from Flourish Medical and Wellness in Savage, Minnesota, where listening to our patients is the priority. Our foundational medicine clinic bridges the gap between traditional and functional medicine. We are pattern recognition specialists that focus on individualized patient care and health optimization. With a combined 30 years of medical experience, our goal is to provide insights that will help you take control of your health. Be sure to follow us on Instagram at Flourish Medical Wellness and on our website, flourishmedicalwellness.com, to stay up to date with what's happening at the clinic. The following content is the opinion of Jackie and Tad Tewes and is not intended to diagnose or treat any medical conditions. Please be sure to speak to your healthcare provider for your unique needs. Hey y'all, Tad and Jackie here from Flourish Medical and Wellness, where our priority is listening to you, our patients, and practicing a team approach to foundational wellness for long-term healing. We are back today with a super exciting series that I'm really excited about bringing to you. I think Tad is as well.
Yeah.
But we're going to dive in. Our next few podcast episodes are really going to be around different myths that we hear from patients, or things that our patients are told and they're like, hey, I heard this from somewhere, my doctor, my provider, whatever. Is this true? And so we're going to kind of spend some time diving into these and talking through those. Sometimes it's partial truths and sometimes it's not true at all. So we're going to dive into that. Again, this is just our perspective, our opinion, and what we see. We have note cards because there's a lot of information here and a lot of things that we hear. So we really wanted to make sure we hit on everything. This month, May, is Women's Health Month. And so we are using this time to really focus on all kind of girls, women, female stuff and myths that we hear. Okay, so first one, I probably hear this more than Tad just because I tend to see a little bit younger patients, but it is normal for your daughter to get her period as early as age 8. So this is, I actually just heard this recently from a patient, and this is kind of what we're being told. I personally don't consider that normal, right? This is a change that has occurred over the last several years. And so to me, that makes me ask the question, well, why? Why is this happening? Because this wasn't what was happening years ago. And so here's what we know. There are two big pieces that play into this. Number one, environmental toxins, which is kind of what we talked about in our previous episode. So if you missed that, go back and listen. But I had a patient last week, upper teens, I believe, if I recall her age correctly. And these were the handful, there were several of toxins that were high in her that directly disrupt her endocrine hormone production system. So BPAs, plastics, that can be in plastic water bottles, that can be in food storage containers. It's also in beverage cans. So if you've ever seen that video floating around out there where they dissolve the soda can, but what's left is still, the liquid is still in there because it's in a plastic coating. So even beverage cans have some BPA in them. 4-nonylphenol, TCS, which is going to be an antifungal, antibacterial that is put in a lot of our products, our cosmetics and different things like that to keep them from growing mold and bacteria. 2,4-D, which is an herbicide, atrazine, which is a pesticide, glyphosate, another one. So these things are sprayed on our grass, on our foods, on our plants, our crops. We are inhaling them, we're eating them, we're drinking them in our water. I almost always see high levels in these when I do toxin tests on 4-year-olds or 50-year-olds. So it's a very significant problem. Methylparabens, mono 2-ethyl-5-hydroxyhexyl phthalates. So phthalates are a huge one that is going to disrupt our endocrine system. And then we have PFAS, those kind of forever chemicals that we're learning more and more about. These are going to be found in things like nonstick cookware, waterproof clothing. And we just heard this last week at a conference we were at, in Lulu leggings. Yeah. That was a new one for me, but
widely bought.
Yes. So one of the most popular things, especially in our teen girls, like think about it. Teen girls, this Lulu trend, that's what they want. These clothes literally absorb into their skin, even their, you think about like the areas that it's touching on your skin, and it's directly changing their endocrine function. So this is a huge problem. This was just one person's test, that all of these things were super high in that should not be high levels in the body. The other piece of that is going to be, we tend to see a higher body fat percentage across all ages here in the United States. And so this contributes to an early onset of menses. Increased body fat actually stimulates the pituitary gland to increase hormone production. So that's another big issue, just our foods. What are we eating, and what is our cardiometabolic health?
Absolutely. And there's several studies that back up just that change in onset of menses over time, especially in the United States. And like Jackie had said, this is so multifactorial. It is the things we're exposed to, the things that younger girls are exposed to. Eating habits is a huge part, as well as just the processing of foods and different additives and estrogen disruptors, hormone disruptors that are even involved in the processing of mass-produced foods.
So if your child is 8 and they have breast buds, or they have things happening that you're like, wow, I was not expecting this, and I don't feel like she is at an age where I can have this whole puberty, you're going to start getting your period talk. Doesn't have to be that way, right? Like, these are the things that are causing it, that are triggering that. It's not normal. And more importantly, to understand, there are things you can do about it. I had this conversation this week too, and a mom was like, I just feel so bad. Like, she's 8 years old. I don't even know how to talk to her about, like, this thing's going to be happening to your body, and you have to take pads to school and all this stuff. They don't have to. Like, that's not the end. We can step in and we can work on reversing and getting rid of some of these things that's contributing to that. So if that's you have a kiddo in that predicament, if that's what's going on, like, you can do things. Okay, it's not just how it is. All right, good?
Yep.
All right, number 2, heavy, painful periods are normal. This is another one. Okay, I hear this all the time. I don't know if you hear this a lot, or if it's more in the teens. Heavy, painful periods are not normal. That is not a body's normal response to a menstrual cycle. That is a sign that something is wrong, that your body is not working appropriately. It can be so severe that girls can't go to school. They're vomiting, they're throwing up, they're having extreme pain, they're super dizzy. They go to the doctor. What do?
Birth control,
which we'll talk about. Not good. That's not fixing anything. That's just giving their body basically fake hormones and completely changing the way their hormones are working. So it's not normal. And yes, again, there are things we can do about it. Where does this come from? Xenoestrogens, again. So we kind of talked about some of those products, and some of the toxins that I just mentioned include xenoestrogens. Think of xenoestrogens as fake estrogens. So they're estrogen mimicking. So they're similar to estrogen, which then can allow them to attach to estrogen receptors in the body. And the body is like, wait, what is this? Like, it's attaching, but it's not really right. So things aren't working well. And a lot of times when we're getting these symptoms, it's your body's protective mechanism saying, hey, this isn't right. Something is wrong here. So we really need to listen to those things. When we see a lot of xenoestrogens, it's going to clog up that liver. Remember, your liver is your toxin toilet, so it has to flush everything out, good or bad, that we come in contact with. And when that liver gets clogged because there's too much for it to flush out, then it starts to recirculate in the body. So it's not coming out, it's sent back into our bloodstream, we're recirculating, we're causing more of an issue. So heavy, painful periods are not normal. These xenoestrogens are going to be found in things like cosmetics, plastics, dish soaps, detergents, again, glyphosate, atrazine, those pesticides, those herbicides. So things we use every day, very, very common things. The second biggest thing that I see causing heavy, painful periods on a pretty regular basis with patients are going to be parasites, okay? Parasites are very, very common. In fact, we are the only country that does not routinely deworm ourselves, right? I don't know why. There's risk for all of us to have exposure to parasites. We are not immune to them because we live in the United States. They are found in our water, in our foods. We can get them from pets. It's not something that we're immune to. And parasites don't just affect the gut. I think most people think about parasites living in the gut. Yes, absolutely. And that's a common place that we find them, but it's not just there. You can have parasites in the uterus. You can have parasites in the brain, like they can be in other places. And so this is another big one that I find. We have some lab work that we do that can show us kind of some clues or signs that parasites may be present. And as we walk through getting rid of those numbers come down, their period symptoms get a lot better. So heavy, painful periods are not normal.
Yeah.
Anything you'd add there?
Well, and as we're seeing more and more insulin resistance, especially in our younger ladies, that absolutely can be a contributor. Disruption of the gut microbiome too, because we're eating a lot of processed foods, because of disruption or different values of those good commensal bacteria compared to some of the more negative acting bacteria, or those bacteria that can cause symptoms when they're out of balance or increase too much. Those also can contribute to periods and overall inflammation as well.
Yeah. All right. Number 3, birth control will fix it, and it's safe. It's completely safe. Okay. So before I go into this, I will admit 100%, this was a tool in my toolbox that I used to use, and I used to give out way more than I'm proud to admit when I was practicing in the traditional world. I 100% now see on a daily basis the impact that birth control has on our system and on our overall health and longevity and our long-term hormone production. So birth control is made to suppress the signal from the brain to the ovaries to stop production of your hormones, your estrogen, your progesterone. That's what it's supposed to do. And then it's putting in these kind of fake estrogens or progesterones so that your body doesn't ovulate and allow you to get pregnant, right? That's used a lot of times in these heavy period situations because it can help with symptoms, because you're getting different levels of hormones. Maybe your estrogen was too high, which is why you were having heavy periods. But again, why was it too high? There's other causes that are making that. And so instead of us going to that cause of saying, hey, it's too high because you have high xenoestrogens, we're just instead giving them a fake hormone that's going to drive down their natural production, but not actually do anything and fix how the body's working on its own. I remember the very first time I got labs back on a woman who was on birth control. I was like, what is happening? I was like so confused. When she was seeing this too, I'm sure. So when we get those labs back, what do you see?
What you'll see is suppression of the signal from the brain. So specifically when you look at like follicle stimulating hormone from the pituitary gland, because the brain, it is sensing every second of every day what is in the bloodstream, and you have those hormone mimicking molecules or synthetic molecules where the brain says, hey, I'm getting something here. I got to make sure that we're not producing this naturally at the same level from the ovaries. And so we're shutting down, or we're really augmenting that feedback loop from the brain to the ovaries and vice versa, based on what's in the bloodstream.
And then their estrogen is?
Oh, almost nothing.
0.
Yeah, it's
right?
very suppressed.
So typically a normal set of labs for a pre-menopause, so not perimenopause, pre-menopausal woman should have an FSH, which again is that signal from the brain telling the ovaries to make hormones, somewhere between
2 to 7, depending on
or
where.
even up to the 10s, 13 maybe, right?
Sometimes.
Okay, and then your estrogen is going to fluctuate depending on where you are in your cycle. And so that could be as high as 200, that could be 40, like it's going to range. That's what we should see. Okay, so when we get these women back who are on birth control, their estrogen is 0 and their FSH is super low. And typically when we see estrogen is 0, we think menopause, right? So if you would just base the labs on what you're like, just look at the labs and not have a good clinical picture of what's going on with your patient, you'd be like, wow, what is happening here? Why is this woman at 15 not making any estrogen? So it absolutely impacts our normal hormone production.
Yeah.
Okay. SHBG, so this is the other thing, and I'm sure you see this on labs all of the time. So SHBG, sex hormone binding globulin, is a protein that can bind and block and kind of block up our hormones so our cells can't use them, our receptors can't receive them. So this is something that I see all the time. If someone is actively on birth control, that SHBG level is going to be 100 plus, even sometimes 200. Ideally, we want that to be, 70 or under. And so it's super high. This then impacts our other hormones. So this moves on from just being an estradiol and estrogen progesterone issue. It becomes a testosterone issue as well, which has so many other systemic effects. And the hard thing is this doesn't always go back to normal. Mm-hmm. There are some things that we can do to try and lower that SHBG, but some women, it doesn't rebound. And so they forever have too much of this blocking protein, now disrupting hormones on a whole other level.
Yeah. When we look at SHBG, sex hormone binding globulin, it actually has a higher affinity for testosterone than estrogen in the bloodstream. And so yes, we're going to see that number get driven up by the estrogen, but the testosterone that women also need is the innocent bystander that gets shot in the process. And so when younger ladies or even women in their 20s and 30s start saying, hey, I'm having these cognitive changes, or I feel like I'm having more inflammation, my joints hurt more, I saw a big drop in libido and sexual function, that's that testosterone, the innocent bystander, getting shot by SHBG in the process.
And this is a really good time just to remind people out there, if you've seen us, testosterone is just as important for women as it is for men. We actually make more testosterone in a, middle, young age woman than we do estrogen on a daily basis. It's a really, really important hormone for us, and unfortunately it gets overlooked many times. So the other thing that oral birth control, synthetic birth control, can impact is our liver. Like we talked about, it is hard for your liver to break down synthetic hormones. And so it causes more of that clogging like we talked about. There is an increased risk of hepatocellular adenomas, and it has been shown to impair bile flow in the liver, creating and leading to some different types of stones, gallstones, that kind of thing. So we know this, but tell me the last time your doctor, when they put you on birth control, told you this. When was that? Did they have that conversation with you? All right, our gut. That is another thing that is impacted by birth control. So we know that oral birth control or synthetic birth control decreases the diversity of our gut microbiome. This can then lead to increased permeability, meaning things are getting in and out of the gut that shouldn't be getting in and out of the gut. Then triggers inflammatory response, immune response, can contribute to some autoimmune stuff. Like that's a whole cascade of things that then can happen when we have increased permeability. We can also see this leading to an increased overgrowth of things that shouldn't be there, like yeast. The number of times we have patients with chronic yeast infections or candida all the time. And this is because that microbiome has been changed, the diversity is altered, it's lowered. Now we don't have the good protective organisms in there keeping this bad stuff away. It can also lead to some IBD symptoms as well. So some different types of irritable bowel. And blood clots. We'll talk a little bit more about this and how estrogen plays a role in that, but we do know there is an increased risk of blood clots when people are on oral contraceptives or synthetic birth controls. Again, are you told that when you put your teenage daughter on it? And the last thing that we can see as far as birth control is it can deplete nutrients in our body, including B12, B6, folic acid, and magnesium. All right.
Myth number 4, you're tired and you're getting older just because you have kids. And this is something that we do hear from patients pretty regularly, especially women in their 20s and 30s, that drop in energy or that drop in overall function is just a normal part of aging that they should expect. The big pieces that go into this is from a hormonal perspective. Testosterone is that first major sex hormone to really drop off in a woman's 20s. And as that testosterone drops off, things that we see is changes in physical function, changes in energy, potentially cognitive changes, so things like brain fog, more word finding. You probably hear that all the time from women.
I feel that.
They get in their 30s and they say, I'm in conversation and I know what the word is, I just can't get it out of my mouth. You can see changes also in sexual function and relationships. And then the other piece to testosterone, just from a hormonal perspective, is it is that calm, confident ambition hormone for women. So when we hear women say something like, I used to be so much more motivated in my business, or I'm just doing the same thing over and over again, week after week, and I just don't seem to be as passionate. It's one of those pieces that we need to look at, because that shift is really occurring toward the latter half of a woman's 20s most of the time, and that can be a big piece in terms of function and quality of life. The other side is stress, poor lifestyle habits, poor eating habits. Those can all suppress hormonal production, especially in women. And so if we see a lot of cortisol, or we see sleep habits being out of balance, eating habits being out of balance, especially leading to more insulin resistance, all of that impacts hormones, which is going to affect function. And usually that catches up with women beginning in their 20s and 30s, because that's when people professionally are moving into higher stress situations, maybe having kids, so there's a little more role strain too. And hormones can be that innocent bystander. The other piece is going to be changes in thyroid hormone regulation within the body. So our thyroid gland in our neck, it produces several major hormones. The big two are going to be called T4 and T3, and those have hundreds of functions within the body. And what happens is that T4, or the longer acting version of the hormone, is very minimally metabolically active. So it doesn't do a whole lot. It hangs out a long time in the bloodstream, but then we get that converted to T3, which is that super metabolically active form of the hormone, which is going to drive energy and metabolism and all of those organ functions. We typically think about things like hair, skin, and nails, but it plays a huge role in our gut, in our heart, and all over the body. That process of conversion from T4, or the less active, longer acting form, to T3, that can slow down with age. And that's one of those things where the better we are to our bodies in terms of lifestyle factors, typically the more efficient that process will be. The other thing is, when we look at how medications are prescribed in this country, far and away, the most commonly prescribed thyroid medication is levothyroxine, which is T4. T4, that less metabolically active form, depends on the body being able to convert it to T3. And so that's why follow-up lab work is so important, to ensure if a person is just getting T4, that their body is taking care of the other half of the equation and converting that over to that rocket fuel, which is T3 for all of us. The other thing as well is, if we have microbiome changes in our gut, and if we have insulin resistance, all of that is slowing down that conversion process. And because of the lifestyle that we live and the food we eat on average in the United States, many people are just not converting as well to T3, with the liver not functioning optimally if it's clogged up by things like pesticides, herbicides, PFAS chemicals. All of that is going to slow down, because much of that conversion does occur in the liver and the periphery of the body as it circulates. And then beyond that, nutrients also play a role, micronutrients, things like selenium, zinc, iodine, iron also plays a role in that process. So if we have nutrient deficiencies, that's another piece that will slow down. And thyroid's huge. I mean, if a person comes in and doesn't have energy or feels cognitive changes, especially if that person's in their 20s, 30s, 40s, thyroid should be one of the very first things that's checked, in my opinion.
Yeah, so again, you're getting older. Well, yes, you are getting older, and yes, you may have children, but that doesn't mean that you should automatically be tired or have less drive and motivation. And so that's where, just taking a couple extra steps and not just chalking it up to you're older and you have kids. It's saying, well, is there something we're missing? Is there something that we can help the body with? Whether that's we need to adjust your diet to heal your gut, whether that's we need to clean out your liver, whether that's we need, better nutrients, and whether that's maybe you're having some hormone disruption in your thyroid or your testosterone. It's not just because you're older and have kids, that there's usually a triggering factor there.
Well said.
All right, what's next?
Myth number 5, cognitive changes are just part of getting older. Well, you've got brain fog, you've got word finding, you can't quite access that memory as well just because you're in your 30s and 40s, and that's part of life. The big pieces here when we look at cognition are going to be those things that we had actually just talked about with looking at thyroid function. That's a huge piece to that. So looking at not only the controllables or the lifestyle pieces with regard to thyroid, which are going to be sleep, what we're eating, are we getting regular exercise, what does nutrition overall look like, especially the nutrients that support thyroid function, and then also, is there insulin resistance happening? All of that plays a role in us having that thyroid because it plays a huge cognitive component for us as adults. And then the sex hormones too, specifically testosterone for women and men. There are studies and information out that look at testosterone's positive or protective effects on things called amyloid plaques in the brain, meaning that as we develop more amyloid plaques, it can lead to having a cognitive decline and eventually even having dementia because of that. And testosterone tends to play a role in protection of that. So it is another piece to that puzzle when we're talking about overall mental function. Beyond that, sleep plays a huge role, and we both talk about this daily with people, but having a good sleep hygiene regimen is huge. Getting to bed around the same time, setting that alarm clock to wake up at the same time to really set and support that circadian rhythm. Simple things like a cool, dark room, trying to avoid screens for at least an hour before bed, and in a perfect world, trying not to eat 3 to 4 hours before bed. That is going to help with blood sugar and insulin regulation all night as you sleep to help maximize the quality of that sleep, not only REM sleep, but deep sleep as well, to get the most restorative function from that. And then beyond that, the lifestyle habits. So when we think about America, and I'm not going to speak for the rest of the world because I don't know what happens in 2/3 of the world, but in America, what happens is most of us, when we get into our 30s and 40s, we are into our career. And for the vast majority of people, that is going to be a sedentary lifestyle or sedentary work that tends to bring stress with it, whether it's mental stress, emotional stress, role strain, all of those things, especially when we think about people starting to get into their family. So that does play a role in hormone suppression or in those key drivers, those key fuel sources for optimal cognitive function.
For sure. And I would add to that, just our life. Like, I don't know about you, but it seems like compared to when I was growing up, I hear that all the time from people.
Back when I was your age.
It is like our world is so different. It's work. It is kids' activities. It is, trying to keep up with friends and make time to go out and do things. It's now, making sure you're exercising and making sure you're eating well and making sure you're taking time to de-stress. And like, there's all these things, right? And you can't do it all. And so eventually, slowly over time, what I tend to hear from people is that they have to start kind of cutting back or things start to fall off. And that's when we start to see the really healthy habits that are keeping your brain healthy and your gut healthy and your mood, like they start to change. And that's really where we can see a big decline. If you're not sure, like maybe I don't even know what I'm doing that's impacting my overall health on a lifestyle basis, like let's talk about it because we talk about that every day.
Absolutely.
All right, number 6, and kind of from here on out, we're talking about women more toward that kind of last third of their life, that perimenopause and menopause transition. So menopause is a normal part of aging, and you just have to deal with it. The number of times, I know I'm being real blunt here, but
weekly.
This is what people are told. Like, you just have to deal with it. It is what it is. Okay. First of all, I think there's a little bit nicer way you could say that to begin with. But second of all, yes, we're getting older. Yes, it's a part of aging, but you don't just have to deal with it. There are lifestyle things and ways you can support your body to make it easier on your body as far as symptoms and how you're responding. And the other thing that I think gets overlooked and doesn't get mentioned is that it's happening at a younger age. I see that. Like women are kind of transitioning into this perimenopause time so much sooner than what they should be. So they feel worse for longer, right? And then on the backside of that, once they're through that menopause transition, maybe they feel a little bit better. They don't have the night sweats, the hot flashes, that kind of stuff. But now their organs are hormone deficient. And guess what? The majority of our organs have hormone receptors on them for a reason. They have hormone receptors on them because they need those hormones to function. And so we'll kind of go through pieces of all of this. So when I was kind of digging into this, and I can speak for myself, I would like to know what your experience was with this as well. But there truly are very minimal training in medical schools, PA schools, NP schools on menopause. Like I personally do not remember, like there wasn't a full section on this, or maybe a lecture. I don't like. Yeah. There was almost no training on menopause for me.
Yeah, and it is starting to get better. I think that more programs, more curriculums are waking up to this just because as younger girls start to have periods earlier, that's going to follow that. If we think about the ovaries, that's going to cause menopause on average to start earlier, and women are living longer, so that menopausal time frame is longer too.
Yeah. The problem is though, it's not what patients are being told right now. Right? Because it's going to take years and years for that to circle back. So if training is happening maybe a little bit more now, what about all of us right now? What about our daughters? Like the people we're seeing in that medical practice are just telling us, it's fine, deal with it. Like literally, patients are told, you just have to deal with it. So there was a study done by Johns Hopkins in 2013, so fairly recent, that nearly 80% of medical residents felt barely comfortable discussing or treating menopause. 80% were barely comfortable. And those are the people that you're going to and seeking out for help in this really, I would say it's almost even more challenging than pregnancy. Like this can really impact a lot of women in a lot of hard ways. 80% of OBGYN residencies do not offer menopause training. Okay, so when we think about OBGYNs or gynecologists, these are our specialists. These are supposed to be our hormone specialists who are going to know what to do and what to tell us. And I am no way trying to badmouth them or say that they're not doing a good job. What I'm trying to draw attention to here is that the training has not been there. And so unfortunately, when you're not trained on something, you aren't given the tools to help people, you got nothing, right? All you have is to tell them you just have to deal with it because I don't know what else to tell you, right? So that's a big problem as well. The other piece that I think is missed a lot is that there are significant risks with menopause. And it sounds so weird to say that, but there really are risks of menopause. 1 in 2 women will break a bone at some point in their life due to osteoporosis, which then leads to increased mortality. And we know that the loss of estrogen is the most common cause of osteoporosis. That is across the board. All medical societies, providers will agree with that. The loss of estrogen is the most common cause of osteoporosis. That's why we see it postmenopausally happening at a higher occurrence or a higher rate. So there is a risk of losing estrogen for fracture. And a lot of times you see this as your background being in orthopedics, that hip fracture, that surgery, what then happens?
Yeah, after a hip fracture, when you look at mortality rates, 6 months, 1 year, 5 years, it's pretty substantial. And just not only quality of life, but mortality in general really skyrockets compared to their peers who have not had a hip fracture.
And I think a lot of people miss it. They're like, oh, it's just a fracture, right? That it's not just a fracture. There are so many dominoes that start to tumble after that. Cardiovascular disease. Okay, so this is another one. And the American Heart Association, the AHA, actually supports this as well. So it is the number 1 killer. Last I knew, maybe double check me on that, but the number 1 killer of women. Yeah. And this risk is most drastically increased in peri and postmenopausal women. So in 2020, the AHA released this statement. They said, the menopausal transition is more of a risk factor than aging in initiating increases of lipids, metabolic syndrome, and cardiovascular remodeling. Okay, so what does that mean? That means take a 6-year-old, and this is a little bit probably not what we would typically see, but I'm kind of exaggerating so you get the picture. So if I had a woman who went through menopause, maybe a surgically induced menopause at age 30 because they took out her ovaries and her uterus, okay? And so she's in menopause. And then we have maybe a 6-year-old who hasn't really fully been through menopause yet. You would think that, age-wise, the 6-year-old probably has a little bit higher risk of cardiovascular disease, right? What they're telling us and what they're saying is that the menopausal transition, so losing those hormones, that estrogen production being gone, is a higher risk for you than aging. So that woman who was forced into menopause because of a hysterectomy, a total hysterectomy, has a higher risk of heart disease just because her hormones are gone. That's what they're saying. It's because her hormones are gone. So it does significantly impact our cholesterol. Lipids are our cholesterol. We know that postmenopausally, I see this every day, pretty routinely see increased total cholesterol, an increase in LDL cholesterol, an increase in triglycerides, and also an increase in the apolipoprotein B. And the fascinating thing is when you put estrogen back, guess what happens?
Things can improve.
Those things go down. Also metabolic syndrome. So that's going to be looking at, excess adipose tissue, tissue around the organs, fatty liver, high blood sugar, those types of things. The other thing that testosterone and estrogen have a part in is the vasoconstriction and dilation of our blood vessels. So testosterone is a vasodilator. Estrogen, it helps keep circulation flowing appropriately in the body. And so a lot of times we'll see a change in that postmenopausally or when there's those hormones drop. Sexual function goes along with this. So that's why a lot of times as we get older, it's harder for women to climax, to orgasm, because their vessels are constricted. They're not getting good blood flow to the appropriate areas, just like men. Like, it's not uncommon to talk about ED, but it's like, oh geez, don't talk about women and orgasm. Like, heaven forbid, that's just part of aging. No, it's because your blood vessels are constricted and your parts aren't getting good blood flow, so they're not going to respond appropriately.
Yeah, so when we're also talking about aging and menopause, other things of concern are going to be insulin resistance over time. And as a woman loses all of the protective mechanisms of her sex hormones, so estrogen, progesterone are going to be the main ones that drop off around perimenopause and menopause. What we can see is more difficulty controlling blood sugars through how efficient insulin works. So insulin is that hormone that when we eat, our blood sugar starts to go up. Insulin helps to regulate that so our blood sugars don't get too high. But if it takes more and more insulin to do that blood sugar regulatory function, that's called insulin resistance, where we need more and more gas to make that car run, to drive that sugar out of the bloodstream into cells. And that is something that can simply happen as women lose their hormones. Neuroinflammation and neurodegenerative changes as well. Dr. Mosconi, so she is a neuroscientist who had actually done some brain imaging studies that had showed a rapid loss. And when you lose estrogen rapidly as a woman, it can lead to chronological aging of a woman's brain. With imaging studies, they can actually see this, and that's something that absolutely will affect cognitive performance as well. And that loss of estrogen over time, or even having a more prolonged period of being in an estrogen desert, is one of the reasons why dementia rates are much higher in females than they are in males, especially when we look at Alzheimer's. And the last one, genital urinary changes. You had touched on this a little bit with regard to blood flow, but what we'll tend to see is as estrogen drops off, we can see decreased vaginal collagen, elastin. We can also see atrophy of those tissues, which can result in sexual function changes. It can result in urinary tract infections. It can result even in things like bacterial vaginosis, increasing that vaginal pH. And this gets down the wormhole a little bit, but vaginal pH is extremely important because there are specific bacterial species in there which are designed for a female body to thrive and to really have just a healthy biome in that area. And so as that vaginal pH changes, it really can change the flora of what is present in the vagina, and then the urinary tract infections associated more so with the atrophy.
So back to that myth. So menopause is a normal part of aging. You just have to deal with it. Key takeaways are, number one, yes, it's a normal part of aging, but the problem is we're seeing it happen too soon, much sooner than it used to happen. So that's a problem. And then you just have to deal with it. Again, that's simply not true. There are things that we can do to help your body not just survive, but thrive during that transitional time.
Yeah.
And not just symptomatically, but your heart, your brain, your bones, your genitourinary tract need hormones. And so when we're living without them for a longer period of time, these are the things that we start to see. So you don't just have to live with it. You just have to find a provider who knows what they're talking about and how to effectively treat and manage these issues. All right, number 7.
Next.
Number 7. All right, there's only 14, so we're halfway there.
Stick with us.
Okay, I like this one. Hormone labs don't tell us anything. Do you hear that?
Oh, it just breaks my heart.
Okay, so probably again on a weekly basis, they're like, oh yeah, I asked my doctor to check my labs, but they wouldn't check them. Again, I'm not faulting them. I probably would have told them the same thing because of how I was trained, because of what I knew. It's simply what we know or what we don't know, I think, is where that stems from, because they think, well, okay, I'll check them for you, but what am I going to do about them? I don't know what to do about them, right? I don't have any tools to help. And so that's part of the situation, is they don't want to necessarily check things that they're not sure how, like, they don't have a tool, they don't have something to offer you to help. And so that's part of the reason that we're seeing that. But they absolutely tell us things. FSH, estradiol, progesterone, right? These are some of the key ones that we look at. There's a couple other ones that can also really help us understand perimenopause and menopause. But they fluctuate. Yes, it's a picture in time of what's happening. But one of the things that we do here, and it's super important, and I have a very strong, passionate feelings about this, is that you cannot treat a patient based on numbers on a page. Okay, so yes, if I just drew numbers and I'm like, oh, well, this is going to tell me you have strep throat or you don't. No, it's not like that, right? It's not that black and white. But when you have numbers and you know what's happening with your patient, you've spent an hour talking with them about their symptoms, how old are they, what is their history, what is their mom's history with menopause and perimenopause, that combined with those numbers are a very, very comprehensive picture, and you can give them some pretty good ideas of what's maybe happening and kind of where we're headed. And so this can absolutely help us understand perimenopause, menopause, that transitional time. So you have to look at numbers, you have to combine that with symptoms in the clinical picture that you're seeing. The other thing is that typically what we know and the literature shows us is that women with a higher FSH are going to have more severe vasomotor symptoms. So more severe hot flashes and night sweats. And when we see that, guess what happens with that? More vasomotor symptoms, usually higher risk of cardiovascular disease. So these are non-arguable things that the medical community is very aware of and they will all agree on. So knowing what those labs are super important. FSH also, this can be elevated even up to 10 years prior to menopause. And so if women come in, they're like 35, why I think something's changing, I feel like something's off. If we don't check this and they get told, oh, you're just getting older, you're tired because you have children, like we heard before, you might not even know, like, hey, they're leaning towards some early perimenopause. Like this is what's happening. So again, it can be super helpful. AMH, we don't use this a lot, but it is a marker of ovarian reserve. It's a little bit newer when we talk about menopause, but I do think we might be seeing used more often, but it can predict the age around menopause within about 4 years. So for example, if you have an AMH that's greater than 200, it is extremely unlikely that you're going to have your final menses within the next 5 years. So that's just telling you how many ovaries do you have left. Right. And so when those ovaries run out, we are in menopause.
Mm-hmm. And you made a really good point there about FSH, especially when we're seeing women in their younger 40s, late 30s, and they're saying, I'm getting all these hot flashes. What's happening? I'm too young to be going through perimenopause. Things like the FSH or follicle stimulating hormone can provide incredible value because we see how big of a signal the brain, specifically the pituitary, is sending down to the ovaries saying, hey, I need you to make estrogen. So why is the brain sending such a big signal in that 39-year-old woman who expects to be going through perimenopause when she's 49? And that helps us unpackage, like you said, with a good subjective or getting all of that background information.
The other thing I think of too is, those women who come in with frozen shoulder.
Yeah.
Right? I would say the majority of people do not initially think menopause or perimenopause or dizziness or heart palpitations. That's another one. Heart palpitations is a big one. And so you come in and you're like, yeah, I'm super anxious all of a sudden. My heart's racing. I have this arm I can't lift up, but they're 39. And so we send them to cardiology, we put a Holter monitor on them, and we send them to ortho. But what if we just checked an FSH? And what if it's 26 and you're like, oh, wow, okay. Your hormones are starting to kind of drop here and your brain's trying to get those up. That is a clear answer for all of those things going on. And so it can be super helpful. Number 8, you got number 8?
Myth number 8, the only treatment for menopause is SSRIs, antidepressants, for hot flashes and mood changes.
I love this one too.
It's pretty triggering for you, isn't it? So we see this often where a woman who is going through perimenopause or menopause comes in, they've been started on an SSRI or a selective serotonin reuptake inhibitor, very common mood depression medication. And the bottom line is this: can it help with symptoms during that time? It can help with some symptoms in some women. It does not in any way address the root cause. No one is born with SSRI receptors in our body. Nobody's born with Lexapro receptors or Paxil receptors. Those drugs are synthetics. They are made to bind to specific receptors, but they are not something that chemically we're ever exposed to until we take that oral medication. The problem is when we're putting these foreign substances into our body, we're trying to induce changes artificially because of the loss of something our body actually needs. And specifically for women, it's estrogen and progesterone at that time. Testosterone falls off much earlier, but really those perimenopausal changes are going to be estrogen and progesterone, and that loss in estrogen especially can have some pretty significant cognitive impacts and emotional impacts. Progesterone, on the other side, is more of a calming hormone for most women. It can also have huge benefits in sleep, and so progesterone plays the other side of this.
So things like Effexor. I remember when I had my first menopausal woman, when I first started as a nurse practitioner in primary care, and this woman was just miserable, not sleeping, relationship was falling apart, super anxious, gaining weight, hot flashes, night sweats, she's like, I feel like a different person. And I sat there listening, and I'm like, oh my gosh, this is, I have to help this person. What am I going to do? So I had no idea what to do because, again, I didn't get a lot of training on this. So I leave the visit and I'll be right back. I went down the hall, talked with one of our gynecologists in the office, and his response was, well, there's really not a whole lot you could do. You give her some Effexor for her anxiety and it might help with hot flashes. I was like, wait, that can't be all. That's not a good answer. We can't tell this person that. And that's all we know. That's how we've been trained. And so it is, we're using a tool. This is what always gets me too, when there's kind of this stigma around hormone replacement therapy and, oh, it's so bad for you from some of the traditional world. But yet they're willing to give you something, put something in your body that's foreign, that shouldn't be there, to trick your body into behaving differently, to maybe help with symptoms. But they're opposed to putting back in what's not there, because it should be there. It's not enough of it. Instead of giving the body something that it uses and that it should be there naturally, we're really willing to give it something that it shouldn't have. I don't get it. I don't get it.
Yeah, it's the definition of a medical Band-Aid.
I don't get it.
Yeah. The other thing is when when we look at other treatments for menopause, it really is looking at that hormonal situation, how that applies to symptoms, overall health, and disease prevention. And all of our organ systems, as a woman, organ systems are going to have estrogen receptors on. Estrogen is incredibly valuable for healthy aging and disease prevention. When we look at hormone replacement therapy, not all hormone replacement therapy is created equal. We want to use what are called bioidentical hormones, or hormones that are molecularly the same as what a woman's body makes, meaning that we're not putting in synthetic estrogen or some estrogen that has been chemically modified and is foreign to the body. We want to give that woman estrogen at an appropriate dose so that it is providing benefit, but not high to the level where it could lead to some unexpected or adverse effects as well. And that's where things do need to be tightly regulated, and working with a provider that has a lot of experience with hormones.
BHRT, so bioidentical hormone replacement therapy. Oh, so they tell me like, well, yeah, they just, I went back and I saw my provider, told them what I'm doing, and they're like, oh, they're just trying to get your money. There's no difference between bioidentical hormones and synthetic hormones. That is blatantly not true. There is a difference. There is a structural difference in the molecule, which then impacts the way it binds to the receptor on the cell. You cannot tell me that a synthetic molecule is binding exactly like a bioidentical molecule binds. It's not true. Bioidentical hormones are different, and specifically the bioidentical hormones that we use are plant-based, which is also really important. We're not putting in these foreign chemical man-made substances. So that's really important to understand.
Yeah, and the other big pieces behind hormone replacement therapy or hormone therapy are, it absolutely needs to be an individualized plan. Not every woman gets the same dose of estrogen, or not every woman gets the same dose of progesterone at night. They do need to be those natural products, like you said. The estrogen can be derived from wild yams typically, and created into a perfect estrogen molecule. And then having a similar delivery method to what our body does naturally. So we want to put that into the bloodstream without going through the gut, without what's called first pass metabolism, and involving the liver as well. And that's where utilizing things under the skin like pellets will help mimic normal endocrine function, with putting that perfect estrogen into the bloodstream, getting that delivery system optimized. The other thing that needs to be talked about with this, and I'll try and keep it short, is that when we look at the use of SSRIs in this country, so much of this stems from how healthcare has developed in this country, or we can call it sick care too. In our country, we spend more on healthcare than any other country in the entire world, and it's not close at all. And then when we look at outcome-based measures, when we look at the statistics of how healthy we are at certain ages and how we age, we are lagging behind so many other first world countries. We are, for the amount of money that we spend, the results are terrible. And a big piece of that is how Big Pharma has their hand in this. We're one of very few countries that allows Big Pharma to publicly advertise on television and have their hand deeply in the pockets with lobbyists in Washington. And so when we think, okay, well, why is there a prescription medication from a big pharma company that's heavily involved in things like menopause, name the diagnosis, name the disease state, Big Pharma is going to have their hand in all of it because we've allowed that to happen. And that's why we take something like an SSRI and it becomes a commonly used measure when the symptoms are being caused by a hormone deficiency.
Absolutely.
All right, I'm off my soapbox.
I love it. The other thing too that we hear, and this reminded me of a case that you had recently, male, but similar concept, right? It's like, oh, don't give hormones. We can't use hormones because they're not FDA approved, which we'll touch on. They're not FDA approved, but we're going to use Effexor, or we're going to use these medications that they have maybe not been approved for this treatment, but we're going to use them off-label because it can help with some of the symptoms. So it's okay for us to use non-FDA approved medications for some other purpose, but those same providers are saying, hey, don't use hormones because they're not FDA approved.
Yeah.
again, we're double standard. It's just,
Well, and so much of this just comes down to treating the individual. Instead of dropping people into protocol or algorithm boxes, spending time with people, learning their story, truly understanding not only where they're at now in terms of quality of life, where they've come from, and then using the data portion of that objective to put all the pieces together. And that takes time, which is why healthcare has changed.
absolutely. The other thing you mentioned about the pellet piece, we don't just do pellets here. We do pellets, we do creams, we do patches, we do other things as long as they're bioidentical. But the one thing I really like about that, especially in nursing school, because we're administering medications a lot, and it's the right dose, the right time, the right delivery method. Like you have to know those things, right?
Yeah.
And it's the same thing here. It's like if we're given a cream, unfortunately, the delivery method, you're going to see more peaks and troughs with that, where you apply, they go up, they come back down. So kind of this up and down. Whereas that's one of the things I really, really like, and patients really like about the pellet piece is that your levels can be more stable and more steady and more consistent. So you're not having that. And that's more natural to how our ovaries are releasing those hormones. Yeah, there are peaks and troughs, but it's not as severe. Usually you at least have some steady level.
It's not daily.
All right, number 9, hormones are bad.
Blanket statement.
Hormones are bad. They're all bad. They're terrible. They're going to give you cancer and blood clots and you're going to die. Okay, so I'm going to go through kind of a few just studies that we know for sure as far as why hormones aren't bad and what they do for us. So hormones, hormone replacement therapy, or estrogen causes breast cancer. This is not true. And we are seeing many, many more studies come out on this. We are going to have a whole kind of episode dedicated to this in October in Breast Cancer Awareness Month. So we'll touch on it, but just know estrogen does not cause breast cancer. Okay, there are estrogen positive breast cancers where it can feed that tumor, but it is not the cause of breast cancer. It is well known across the medical community that if you never had children, you are more at risk for breast cancer. That's a very well known thing. Why is that? Well, those women had lower levels of estrogen for their entire life, their lifespan. When we have children, when we're pregnant, our estrogen is insanely high, like hundreds of thousands. And so estrogen actually is breast cancer protective, and we see that, but we'll dive deeper into that in October. The Menopause Journal reported women starting estrogen replacement therapy can expect to live at least 2 years longer than non-hormone therapy users, is what they found when they looked at kind of an observational study of those women. So women using estrogen replacement actually live longer than those who aren't using it. There was a research study done in 1990 they found was an 8.3 increase in bone density after 1 year of hormone replacement therapy. That's pretty incredible. Right now, we do not have any good bone loss or osteoporosis medications. It's just let's hope that it doesn't get worse. With these medications that we use that cause a whole lot of other side effects, we don't need to go into that. But the cool thing there too is 1 year of therapy, bone density increased, and when they checked back with these same ladies who had gotten estrogen at 8 and 10 years, they still showed that bone mineral density was maintained. Pretty awesome. There's a 30% increase in skin collagen and thickness with hormone therapy. There have been several studies that have shown the reduced risk of Alzheimer's, improved cognitive function, and improved verbal memory. I will attest to this. I know for me, when my hormones are low, my cognitive function, my verbal recall, completely different. So really, really important there. Hormone therapy has also shown the reduced risk of mortality, heart failure, and MI or heart attack. There was a study done on cardiovascular or coronary artery disease patients, and what they found was that there was an increased 10-year survival rate after a coronary incident. And so in hormone therapy users, there was a 97% survival rate in women who used hormones. In women who had a cardiovascular event who did not use hormones, the survival rate of 10 years was 60%. That's a huge difference. So women getting hormones for their heart after they had already had a cardiovascular event, their 10-year survival rate was about 90%, 97% had a 10-year survival rate. Only 60% in those who were not using hormones. Estrogen, we see this every day, lowers LDL and increases HDL. So it's really bad, right? Hormones are really bad for you. Hormone therapy also has been shown to improve blood pressure and blood sugar. This is one that I hear often. You probably do as well. Hormones cause blood clots. Do you hear that?
I do.
You hear that? Okay, so there was recently it's called the ESTER study in 2007, and it did show that oral estradiol is associated with an increased risk of clotting. And so don't use oral estrogen, right? This is not true for other delivery methods like topical or subcutaneous. And so that's something that we make sure we don't use for patients, because if it's not safe, we're not going to recommend it. Micronized progesterone and non-oral estrogen do not alter plasma concentration of prothrombin. This is what they saw in the study, is that some of those clotting factors are not altered or changed or increased when we're using micronized progesterone, so bioidentical progesterone, and non-oral forms of estradiol. The International Menopause Society Journal in 2012 found that, again, oral estrogen does affect the coagulation cascade, so that thrombin and protein C specifically, but this was not seen with subcutaneous implants or topical methods. So again, going back to what Tad had mentioned, the delivery method matters. It changes the risks associated with that. So the myth was hormones are bad. So again, I think it's pretty clear that hormones themselves are not bad. In fact, it's opposite. They have a lot of really good benefits to them. So why are we told this, right? That's the question, is why is this idea that hormones are bad? And so to understand where that came from, we really have to look back to what's called the WHI study, the Women's Health Initiative study. This study started to come to be around 1991 and then went through about 2005. And it was the largest women's health study that had ever been done. And it is where all the chaos started. And so interesting to know, prior to this study being done, the reason they were like, hey, we need to study this, is because the NIH had released a statement saying that estrogen was the best way to prevent bone loss in menopausal women, and it increased the risk of cardiovascular disease and neurodegenerative disease. So pre-WHI, medical communities and societies and practitioners were like, hey, hormones are great. They're helping with bone loss. They're helping protect your brain. They're helping with cardiovascular disease. 40% of women ages 50 to 75 around that kind of mid-90s time were using hormone therapy because they knew how great, they saw how good and protective that it was. So insert WHI study. So in this study, they had two groups. Group one was the estrogen and progestin group, and they were being compared to a placebo. So estrogen, the type of estrogen they were using was oral estrogen, and it was pregnant horses' urine is what where they were extracting this from, or Premarin. And then progestin, which is a synthetic, not a bioidentical, not an isomolecular, not the same molecule, a progestin or medroxyprogesterone acetate. That was the first group compared to people not getting any. And then the second group was the estrogen only compared to people not getting any. So they have them on these hormones. Again, oral estrogen, which we just talked about, is not good, and non-bioidentical progesterone. So the group one in 2002, what they found was, so this is estrogen and progestin group, there was a reduction in colon cancer and osteoporosis and fractures related to osteoporosis in the group using hormones. Great. There was a slight increased risk of breast cancer as a relative risk. So this is important to understand. So slight increased risk in breast cancer in the estrogen progestin group, okay? And that increased risk, what it really was there were 4 women who developed breast cancer in the non-hormone therapy group and 5 women who developed breast cancer in the hormone therapy group. So think about that. It only went from 4 to 5, one extra in the hormone treated group, but it was this big estrogen causes breast cancer outcome. So they presented the relative risk as being a 25% risk, but the absolute risk, the actual risk of that was 0.08% higher risk of breast cancer. And so that was a big error on how the researchers had reported this. And they actually came back and corrected themselves publicly, but that wasn't given to the public. It wasn't broadcasted in the same way that hormones are bad and they cause breast cancer.
Yeah, it was more broadcasted as a 25% increase in risk.
Yes, when it's actually only 0.08% increase from that study. All right, in the group 2, so estrogen only. Love this. So group 2, again, they found a reduced risk of colon cancer, reduced rate of colon cancer, reduced fractures, so stronger bones, and no increased risk of breast cancer. Okay, so no increased risk of breast cancer when we got rid of progestin, the fake synthetic progesterone. No increased risk. There was a small increased risk of stroke, heart attack, and pulmonary embolism. Why? Again, because we're using oral estrogen, right? So this study was so important. Unfortunately, it really changed the whole narrative of hormones, and many, many women suffered without hormones for a really long time because of it. But we did learn really important things, that delivery method matters, types of hormones that we're using matter. And so there are really good benefits from this study as well. Unfortunately, a lot of the narrative still in the medical community is that hormones are bad, and they don't understand really what those studies were showing us, or that there's other options than progestin and Premarin. Okay, I think I kind of touched on each of those. Interestingly, they did a 10-year follow-up of these same participants, and in the estrogen only group, they actually had a 40% lower risk of MI or heart attack than the placebo group. So much lower incidence of heart issues in that estrogen only group. A 30% reduction in breast cancer incidence. So women treated with just the estrogen, even oral estrogen, had a lower breast cancer incidence rate than those not given estrogen. And super cool, there was a decreased recurrence rate in those breast cancer patients in the hormone group. So the women who had breast cancer and they were given hormones were less likely to get breast cancer again if they were given hormones than those who weren't given hormones. The ones who had breast cancer, didn't have hormones, had a higher risk of recurrence in that breast cancer. So again, what does this tell us? Estrogen does not cause breast cancer, and there is some literature, and I think we'll see more of this, that is actually protective for the breast and beneficial for the breast.
And from a 10,000 foot view, this is a lot of information on hormones. The important things to understand are hormones can play a big role in symptoms and aging and health and wellness in women. But also make sure that if you're wanting to have that discussion about hormones, you're doing that with a provider who works with hormones day in, day out, and understands the role of them, how they can be used very responsibly and to the highest value as another tool in the toolbox. Because they're not the only tool in the toolbox in perimenopause and menopause.
For sure.
All right, I'm up.
You're up. We
All
cleared up the air on hormones being bad.
All right, myth number 10, hormone replacement therapy is only for hot flashes, night sweats. I would add sexual concerns as well to this. But the fact is that's just not true. Hormones have hundreds of functions in the female body. A study out of 2021 looked at testosterone and estrogen, women receiving testosterone and estrogen therapy, and reduced fracture risk was upwards of 40% in those women. So again, stronger bones, better bone density, and that's because of the effects of both estrogen and testosterone, not only on maintaining bone density, but also what are called osteoblasts, or those bone-making cells, osteoblastic activity. And we can see some of that with both estrogen and testosterone, even a little bit more so with testosterone, I would argue, in women. There have been 19 randomized controlled trials that have shown up to a 50% reduction in cardiovascular disease with hormone replacement therapy in women. Again, that's when it's done the right way, with bioidentical hormones, no oral estrogen, staying away from also progestins or those synthetic non-bioidentical progesterone. Another little piece on progesterone. Progesterone is a big molecule. It should be delivered ideally with a capsule, typically taken at night because it's going to make most women tired. If you're out there taking your oral progesterone in the morning, please change that because it's going to make the rest of your morning pretty rough. Take it before bed or after dinner instead. And again, staying away from oral estrogen. Research out of 2023 showed that hormone therapy users had improved memory. And this is the really important part. Larger tissue volumes in those processing and memory areas of the brain. So when we think about cognitive function, and I'm not just talking about imaging studies, but then how it pertains to daily quality of life with regard to memory recall, verbal function, word finding in conversation, being able to problem solve, and creativity as well can be part of that. Those are things that can all improve when the brain is adequately fueled with the appropriate sex hormones in the appropriate levels. And then looking at symptom relief, quality of life. What am I missing? What other symptoms can you think of with hormone replacement therapy?
Obviously, vaginal symptoms, joints, so you think about estrogen as a lubricating hormone for the vagina. It's lubricating for other areas as well. And so that's where we can see it. So the joint pains, the frozen shoulder, like we mentioned, the heart, the palpitations, not just heart attack, but just general cardiac function, dizziness.
Yeah. And to piggyback on that with joints, so testosterone and estrogen work together for a woman's joints. Testosterone is inherently anti-inflammatory. Estrogen is a lubricating hormone for joints. So when you get better lubrication in the joints with that hormonal super ibuprofen testosterone, it's no wonder that women can move better. And we use that as a tool to help get women back into those good, healthy lifestyle habits, which will promote wellness for a longer period of time.
Yep.
All right, number 11, bioidentical or compounded hormones are not regulated. The fact is they are regulated if you look at 503B pharmacies. So when we look at compounding pharmacies, first and foremost, not all compounding pharmacies are created equally, but pharmacies that we utilize or partner with are what are called 503B pharmacies. And these are regulated by the FDA. They have the same CGMP guidelines, meaning that when we look at the regulations of how they manufacture, make pellets, make hormones and products, they are held to the same standard as mainstream pharmacies because of those CGMP regulations. And that's really important. That's why we vet the pharmacies that we work with. And that's a really important part of just the process of how we function as a clinic.
So I will piggyback on that. Not all compounding pharmacies are FDA regulated, right? So only 503B. So yes, you can use a compounding pharmacy that's not good, and we would not recommend that, obviously. But this blanket statement that all compounding pharmacies are bad and they are FDA, it's not true.
Yeah. And unfortunately, there needs to be more research done by individuals who make that claim.
Yep.
When we look at variance rates as well, so if we look into medications, so a generic medication can typically have a variance rate of up to 25 to 30%. And what that means is if you are getting a 100 milligram medication, it could have an actual dosage of what you're getting from anywhere from upwards of 130 milligrams down to, let's say, 70 to 75 milligrams on the bottom level. And as a generic, that is acceptable. That can be dispensed to a person who needs that medication.
Not compounding pharmacies.
Correct.
Regular pharmacies.
Correct. These are not compounding pharmacies. And you think of all the generic medications that are out there, and there's a reason why sometimes people will feel like, hey, this was a better month than what I got last month. Or I've had a little bit of up and down in my dosage this month, or the effectiveness of it. Part of that can be a variance rate of up to 30% in a generic medication.
Birth control.
Yeah.
I got this pack and I had spotting, or I felt super off emotionally. I see that one a lot. And a lot of that's because of that variance rate.
Yeah, and with trade medications, so brand name medications, those are going to be the more expensive ones. You hope you have insurance coverage for that. Those will have a variance rate typically of up to 10%. So a tighter variance range, that 100 milligram trade medication, up to 110 milligrams, down to about 90 milligrams for what you'll actually get in that capsule or in that pill. Whereas when we look at these compounding pharmacies, the ones that we use have a variance rate of up to 3%. So a very tight window. Let's say I'm giving 100 milligram testosterone pellets. Each of those pellets is going to be somewhere between 97 and 103 milligrams. Very tightly regulated, and we need it to be that way. Because when you're getting a medication, regardless of if it's hormones or something for mood or something for your thyroid, you want that to be as close to that perfect level as possible. And then also to know that from prescription to prescription, you're not going to have a big swing there in terms of dosage.
Yeah, and I would say that's even more important when we are dealing with hormones, because small fluctuations can make a difference.
Absolutely. All right. Oh,
number 12, you got it.
Again.
You're up again.
Pellets are bad. I have had a couple patients come in saying, well, I had a provider tell me that hormone pellets are bad. Number one, I've had people say you can't control the dose. The truth is, yes, we can control the dose. We have pellets of different sizes, different milligrams, and we can adjust that to each person. And that's part of personalizing treatment. It's actually much more personalized than most medications in terms of the exact amount, especially for women, that we can give of the big three: estrogen, testosterone, and progesterone, and being able to give those in just that right amount for that woman. Or if she's doing great on the hormone front, not even going that route. So there's definitely options there. The other piece is when we look at topicals, so things like patches and creams, the skin is a barrier for a reason. Our skin is incredibly made. It's designed to protect us. It actually has tons of different functions, but absorbability through the skin differs from woman to woman. If we had 10 different women in this room right now, we gave them all the same dose of topical estrogen to absorb, and then we tested their blood 2 hours later, we would see different changes in all 10 of those women. It would not be the same change in blood serum level of estrogen, even with the exact same dose that we're giving topically, because that absorption can vary so much from person to person.
We have pelleted thousands of patients, and I 100% have seen it and experienced where it is much easier for me to understand and know what that woman's absorption will be from a pellet than it is from a topical cream or a patch. Again, the skin's a barrier. It was made to keep things out. That's how we were designed, made to protect the inside. So trying to put things in is not always super easy. And so in my experience, it is much easier to control the dose in that sub-Q form.
Yeah, and all the time too, we do see women coming over from other clinics who just are not seeing adequate results with topicals because of the variability of absorption. The other piece, I know we're talking a fair amount about pellets here, make sure if you have interest in hormone pellets, or if you have a friend, family member who has done this and said, hey, you should look into this, make sure you're going to a clinic that is very well versed in hormones and pellets. This is one where I would highly recommend staying away from an aesthetic clinic that kind of does hormones and pellets on the side. It's just not a good route to go. And that's something where you want providers who are having these conversations every day, all day, understand women's health and men's health, and also those changes through aging too.
And I think, that's not a blanket statement. Some are able to do both very well.
Yeah.
It has been my experience that I've had more patients coming from clinics of a similar function where it's not their primary focus. And more importantly, they're not looking at the whole body. And hormones affect the whole body. And so if it's literally just, here's your hormones, you can really get into a lot of trouble with that. We have to know what's happening with our liver, what's happening with our gut, what's happening with our nutrients. There's so many pieces that go into it. So you do have to be careful with that and make sure that the the clinic, the provider that you're using is looking at the whole picture and not, well, we mostly do Botox and we also do a little bit of pellets.
Yeah, absolutely. And then the other knock that I've heard from other providers on pellets is, well, you can't take them out. Then what? And the way that you approach that is being conservative with dosing and being able to say, hey, we're going to start with a lower dose. We're going to go slow, and we'll get blood testing following the pelleting to know exactly how your body responds. And you pair that data post-pelleting with the blood work along with symptom improvement, quality of life. And that's what allows you to be in that sweet spot, not only for providing enough hormones for getting those receptors, getting that protective function, but also the improvement in things like brain fog, sexual health, physical function, energy, and all the things that our hormones fuel.
Yeah. All right, 2 left. 13. A partial hysterectomy won't affect or impact menopause. Unfortunately, this is also not true. So a partial hysterectomy means the uterus was taken out, but the ovaries, or at least one ovary, has been left. And unfortunately, I have a lot of women come in, they're like, hey, my doctor's recommending this. And I'm like, hey, did they talk to you about risks? Like what that might look like? And they're like, well, there really aren't. Other than the surgery, there really aren't a lot of risks long term. So what we see is that even if the ovaries are left in place, the blood flow to those ovaries can be compromised, which then can lead to an earlier onset of menopause by about 4 to 5 years. And so there is no like, hey, this is completely safe, it won't impact that at all. That's just not true. If only one ovary is left, we'll see it accelerate menopause by an additional 2 years on average. The number of times that people come in and are like, I had a hysterectomy, even a partial, and they're like, the next day or 2 days later or the next week, I felt like a completely different person in a not good way. I wasn't sleeping, I was hot, like all the things. It's pretty remarkable when you hear that and you realize, wow, I mean, I even thought partial hysterectomies really didn't impact that much, but I see it frequently where it can really change and create a more sudden onset of that menopause. Yeah. Okay. Last one, hysterectomies are safe. So, they do have some risks surgically, but I'm talking about more so looking at safety when it comes to overall health and wellness. Okay, so the literature shows that women with hysterectomized women, so women who've had hysterectomy, actually have a 28% increase in overall mortality, so death from all causes, a 33% increase in heart disease, a 62% increase in stroke, a 60% increased risk of cognitive impairment, 54% increased risk of a mood disorder, depression, anxiety, that kind of thing, and a 50% increased risk of osteoporosis and fracture. And every single one of those goes back to the literature where hormones support our organs, they support our organ systems, they support our brain, they keep our bones strong, they support our heart. So the message is very clear and consistent when you look across the board, how hormones can really positively impact our body. And so this whole idea that just having to live with menopause or heavy periods are normal and we should just give birth control to fix that problem, which then long-term impacts our overall hormone production, it can get really messy. So hopefully there were some good pearls that you were able to take out of this. Again, we are not here in any way to speak negatively or poorly about any other practice or clinician or doctor or provide nothing. What we want to do is provide truth and clarity from what we see and our patient experiences. And again, when we're pulling from thousands of patients, I think we have a pretty good lens on what this looks like. And so we've been blessed to be able to do that. Again, hopefully you were able to take something super positive away from this. And I'm excited to continue this series of myths and kind of dispelling those things. This was one of the things that when we talked about the podcast, we're like, yeah, we got to do this.
Mm-hmm. We do. And definitely reach out if you have any questions, reach out to our clinic. We're happy to help. And otherwise, everyone, God bless.
Thanks for listening in to the Flourishing Life podcast. You can watch this full video version of this podcast inside the Spotify app or on our YouTube channel. If you like this episode, please rate, review, and subscribe on your favorite podcast app. And be sure to share this episode with a friend and follow us on socials at Flourish Medical Wellness and on our website at flourishmedicalwellness.com. The information on this podcast is for educational purposes only and is not intended to replace medical advice or to be a substitute for professional medical diagnosis or treatment.